On behalf of Welcome Sir, I Vinod Kumar Verma welcome our moderator, our speaker, and all the doctors who have joined us sir, on today's virtual webinar on our comorbidity of depression and anxiety disorders and their recognition and management. Sir. Welcome has always been in forefront when it comes to the scientific dissemination of our knowledge. Comorbid depression and anxiety, sir, is a new normal in step forward in that direction. Comorbid condition with depression and anxiety is on high rise, especially in these challenges conditions, sir. And time to cater that, we would like to have our experts to give us our direction based on their experience and their expertise. To help us to navigate through the meeting, we have with us Dr. Parminder Singh, who will be our moderator for today's webinar. I welcome Dr. Parminder Singh, who is working as an associate professor in Department of Medicines in SGRD Medical College and Hospital Valla, Amritsar. He is also medical consultant in Life Care Hospital, Amritsar. He has a rich experience of more than 7 years of practices. Dr. Parminder has done his MD Medicine from Dayanand Medical College in 2013. Dr. Parminder has special interest, especially in the infectious and rheumatological diseases. And for our panels as a speaker, we have with us Dr. Piyush Mahajan, who is a renowned psychiatrist, MD psychiatrist, and is a gold medalist. Dr. Piyush Mahajan is practicing currently in SDRD Medical College and Hospital, Amritsar. He is having a special interest in mood disorders and even psychosexual health, addiction psychiatrist, and even child and geriatric psychiatrist. He is morally seen active in many academic and research works. He is keep writing and speaking about various mental disorders and related experts in various social medias. So, I welcome Dr. Piyush and Dr. as a speaker and Dr. Parminder as our moderator. And now I would like to hand over our session to Dr. Parminder for letting his views on our general comorbidity and depression.
Thank you very much for elaborating my profile. And first of all, good afternoon, everyone, and I welcome you to the talk. First of all, I would like to talk about depression as such. See, in last 7-8 years of my practice, I have been observing as a physician that depression and anxiety are one of the two common entities which have been undiagnosed, unfortunately, as well as poorly addressed, especially when the patient lands with the physicians or non-psychiatric consultants. But it is very common. And it is very important for physicians as well as surgeons to look into the patient, not only in terms of surgical or medical diseases, but keep in mind the presentation of depression as somatic disorders. For example, as a physician, I have encountered many patients of hypothyroidism with depression. Later on, when we examined the patient in detail, took detailed clinical history and consultation from psychiatric department, and we found that they are actually suffering from depression. So depression is not uncommon disorder. Unfortunately, it is underdiagnosed as well as under-addressed by most of the physicians. And I was going through literature, and I was surprised that 6 to 8% of outpatient patients which are coming with somatic disorders like loss of appetite, anhedonia, and loss of weight. So they can be actually a presentation of depression as such. Not only the patient of depression can present in medical OPDs or surgical OPDs, but some medical disorders, they can present as depressive illness. And therefore, it is very important that the people, all of us, especially the physician, we should try to recognize this disorder as early as possible so that we can take a proper consultation from psychiatrists and manage them appropriately. And there are many other examples like that. See, I have been seeing many patients of diabetes, especially in this COVID pandemic in last 3-4 months. The patient was well-controlled diabetes, But over the period of last 3 months, they're suddenly landing up in OPD with the uncontrolled diabetes. So when I took detailed history, I came to know that they are actually depressed and they are having a lot of anxieties of getting COVID-19 infection. So our perspective should not only be to treat the patient merely on the basis of medical disorders, but we should, in this time of pandemic, even also during routine practice, we should also keep in mind that patient should be treated as a whole, not as only suffering from medical disorder. We should also keep in mind that he might be suffering these presentation like loss of appetite, loss of weight, loss of interest in usual activities, and feeling of guilt, and these can be the presentation of major depression also. So very surprising, 6 to 8% patient in outpatient, when they are presenting with the somatic syndrome, might be actually a case of major depressive illness. And not only it affects the medical disorders, but also affects the overall benefit, overall condition of the patient. So, for example, I was talking about diabetic patient. Similarly, other patients like hypertension. So suddenly, I have seen in the last 4 months, the patient, they are coming up with uncontrolled hypertension. They were well controlled on drugs. So I think it is very important for us to keep in mind that we should manage these patients not only as a purely medical disorder, but whenever possible, we should try to take a history and to try to find out whether the patient is suffering from major depression or not. Secondly, in spite of medical disorder also, the other reason is that even 3 to 4% of these patients with major depression, they are at risk of suicide. And therefore, it is very important that we address, we should take detailed history. We ask patient whether he is ever feeling of committing suicide. Though patient, most of the time, patient don't disclose, but whenever you spend some time with the patient, and then you will came to know that they are actually at risk of committing suicide. So that is very important. The sooner a physician recognizes that patient is having thoughts of depression, we should take consultation from a psychiatrist. So this is one. Not only overall outcome of the patient depend upon managing major depression, especially when it is occurring with diabetes or other medical disorders, but also it actually increasing the cost of treatment also. And after the few visits, patient become dissatisfied with medical treatments. So I think overall approach should be that we should always keep in mind a major depression, a very common entity, not a rare entity at all. And wherever possible, we should try to take a consultation from a psychiatrist. And today we are fortunate enough that we have today with us Dr. Piyush Mahajan. He's gold medalist in psychiatry. He's a postgraduate from Government Medical College, Amritsar. And he's consultant psychiatrist in SGRD Institute of Medical Sciences and Research. And I have been in long contact with him from last 6 years. And he will today be discussing with us how to address this challenge of major depression and anxiety. And last but not the least, it is not only patient who actually is suffering from major depression and anxiety. And I remember when this pandemic started, and I got a duty roster of COVID posting as a consultant, a visiting consultant. So even I was waiting for my duty. I actually suffered episode of anxiety. So not only it is very important for patient perspective, but we as a doctor in this era of pandemic, we are also facing a lot of anxieties and depression during facing the patient in our routine OPDs. So pandemic has also dramatically changed the way we deal with the patient, and nowadays we are spending lesser time with the patient. So that may be another factor. The more and more patient of medical disorder, they are now actually suffering from major depression, may be missed during a physician routine visits. So I will welcome Dr. Piyush Mahajan to give us our insight on regarding the major depression. And during the talk, we will be discussing the various components one by one. And I encourage all the participants to you are free to ask any question, and we should take advantage of his expertise in managing major depression and anxiety. So I welcome Dr. Piyush Mahajan.
Thank you so much, Parminder sir, for such a brief and very well explained talk about how, as a physician, you see the patients in your OPD. So, as you said, not only the patients, even yourself as doctors, we face anxiety. I still remember a few days back, I saw a patient and I was calling you 2 to 3 times. Sir, I had seen that patient, he may be positive. So, what should I do? Even as I, being a psychiatrist, I was tensed and I was having some anxiety that what will be the outcome of the patient until and unless he was tested and he came out negative. So this is very common these days due to COVID, that we all are having anxieties. So now starting with the patients about the comorbidity of anxiety and depression. First of all, I'll just brief about how you should approach a patient, any patient, in fact. In today's era, most of us, as doctors, maybe physician, maybe psychiatrists, maybe surgeons, we often they find a difficulty in connecting with the patients, and that lack of connection often leads to underdiagnosis that often results in the patient's mismanagement. Though, so what the fault lies is the fault lies in the fact that we often do not empathize with the patient. Whenever a patient comes to see us, we should first establish that how his age, the residence. These 3 or 4 questions start connecting the patient to us and will form a harmonious relationship. Whenever such a harmonious relationship develops with a patient, we, as physicians, will be able to extract information to a good extent, and that will help us in the final diagnosis of the patient. So when we approach the patient, we should always aim for establishing the rapport first, and then we should aim for the diagnosis. So once the rapport is established, we often take history, and the second common lag that happens in diagnosing is the lack of a proper history. So we should always focus on whatever the patient is saying. Not everything we have to focus, but the main points which we as patient think that these can affect his illness. So we should always focus on them, and we should try to go in the detail and to the in-depth knowledge of those complaints presenting to us. So, for example, many a times, whenever it happens, whenever a patient with mental illness presents to the physician, he often presents, as sir said, with somatic complaints. So, what is the most common approach that we have, that we take the history and we go for due investigation of that somatic complaint. Like, for example, if the patient is presenting with cardiac complaints like heaviness in the chest, we go for ECG. And sometimes, even if the ECG is normal, we go for further investigations like chest X-ray, 2D echo, and further all. So, in doing that, we are in no way that we are harming the patient, but we are also delaying his diagnosis if any other psychiatric complaint is present. So, by asking 2 simple questions like, do you feel anxious, and do you have any kind of sleep disturbances? Do you feel anxious? Do you have sad mood? Do you have loss of appetite? These 3-4 complaints can help us in forming a diagnosis in a more better way. So we should always aim for a holistic approach rather than a concrete approach, like only symptom based approach we should always ignore. We should always aim for a holistic approach in the history taking. So if we go for a good history, we have a good history, we often form a good diagnosis. So now coming on to the epidemiology of anxiety and comorbid depression, comorbid anxiety and depression, 10 to 20% of the patients presenting to the physician, out of them 50% are having some form of comorbid anxiety or depression. Again, I repeat that 10 to 20% of the patients presenting to the physician, maybe for any kind of complaint, maybe somatic, maybe diabetes or hypothyroidism or any kind of illness, they are having comorbid anxiety and depression in 50% of the cases. So it is very important to screen such patients for anxiety and depression. So basically, whenever a patient comes to us, how do we go for the screening? We often use some basic questions. Like for mood disorders, like depressive disorders, we often ask the patient, how is your mood, or how is your mood since last 1 month? If he says that my mood remains sad most of the time, and it has been sad continuously for about 14 days as per ICD-10, so we think of a diagnosis of depressive illness. Along with that, there must be certain features like chronic malaise should be there, and a patient must say that he himself feels sad, and this sadness and malaise or fatigue is influencing his day-to-day life. That means his routine activities are being hampered. He's not able to focus on his work. He's not able to fulfill all his homely duties, and he's having personal issues due to this also. Like he does not feel like having a bath, does not feel like eating. He's abstaining from sexual activity. Desires have been lost. So, and along with that, sleep disturbances. So these 4 or 5 symptoms, whenever we ask the patient, he starts explaining to us, Doctor Sahab, I do have these, and they are disturbing my routine activities. For anxiety, we often ask the patient about the common symptoms of anxiety. What are the common symptoms of anxiety? Like we ask, patient often says that I have palpitations without any reason. And maybe there may be a stressor also associated with that, but the palpitation, breathlessness, tremors, and sweating, these often are the pointers toward the panic attacks. So panic attacks are a very common form of anxiety disorders, and by only asking 2 to 3 questions, we can always screen the patient. So the comorbidity, for letting us know the comorbidity, we should first know ourselves what to ask the patient. So as per epidemiology, comorbidity is always there, and we should always know what to ask and when to ask the patient. And why is comorbidity, knowing about the comorbidity important? Because a case of unipolar depression or a case of anxiety, if they present to us individually and there is no comorbidity, it is very easy to treat them, and they have a good prognosis, and they will recover also faster. But in case of comorbidities, the resolution of the illness will take time. The disease will be more chronic. There may be more frequent hospitalizations. There may be more chances of suicidal tendencies in such patients. There may be more chances of substance abuse in such patients. Of comorbidity I am talking. So it is very important to know about the comorbidity, if there are any, and to screen them and diagnose them, and then to treat them. We should not be in a hurry to diagnose the illness which the patient is presenting with. Such kind of presentation often leads to underdiagnosis, and it creates a very problem for us in the long-term management of the patient. So this is the brief approach or the brief introduction about the comorbidities. Now I'll ask sir to go further and discuss about any question that we want to further ask.
Thank you, Dr. Piyush, for a very elaborate introduction on major depression and comorbidity as anxiety. As a physician, I will just like to discuss a few encounters with the patient. And I always ask one question, especially as I think that you will be agree with me that depression is twice as common in female as compared to males in our country. and I used to ask one question to every female, or whenever I suspect that patient is suffering from sort of major depression, that do you feel like crying? And that question, if you ask after spending few minutes with the patient, you cannot ask this question directly. The moment a patient enter into your cabin and you start asking about anxiety and depression is not a good idea. As you told, you first of all spend a few minutes with the patient, and when he become comfortable and develop a rapport with you, then you will ask. I always ask a one question, not as a expert but as a physician, that do you feel like crying? And I surprisingly I have seen many females answering yes, and 50% of them started crying in OPDs. And so I think that it is very important for physicians especially to keep in mind major depression as a very common entity rather than a rare entity. So Dr. Piyush will agree that I have sent many females to her for reference, that it is so common. But the moment a patient enters, she is happy. And the moment she spends some time and you start thinking that his somatic symptom, they are not correlating with any disease entity or medical illness, we have to discuss the issue of depression. And I always ask whether you feel crying anytime, then she say yes. And sometimes they start crying itself. So it is first of all very common in female in our country. And most of the time female are unable to express their feelings. So it is very important that sometimes you take history without any attendant, especially male attendant and family member. Sometimes female don't give you a history of depression because it is a very stigma they are associated with mental illnesses or depression. Still, not only uneducated class, but also very educated people, they feel shy in saying that they are suffering from depression. And second, Dr. Piyush, I just want to ask you, some of my patients, especially diabetic and hypertensive patient, they usually came with complaint that there is some seasonal variation in their symptom. Some people say that during when there is a changing season, they feel more episode of depression, more episode of anxiety. So is there some relationship between depression and anxiety with the season, or what is? Please give us some idea about the seasonal variation and how to address this component.
Yes, sir. Yes, sir. Sir, before answering this question, I'll just brief about something about unipolar and bipolar depression, because this is the base to your question. A unipolar depression, it mostly presents as like someone has a stressor in life, maybe a separation from his wife or some lover, and maybe any kind of loss, a death of a family member, a financial loss. And following that, symptoms start like sadness of mood, and the sleep pattern has been disturbed, fatigue, malaise, loss of appetite, and these 3-4 features. And the patient comes and says that I have been having since last few days, and these have been disturbing my personal life. So this is basically a unipolar depression. So what is bipolar depression? Bipolar depression, it can also have a stressor, like as I said, unipolar depression, and it can start with an episode of after an episode of stressor. But a bipolar depression or a bipolar disorder, the diagnosis is always made in the long term, when the patient keeps on coming to us. Like, for example, he may have a first episode of depressive illness, and we'll quote him as unipolar depression. But after 6 to 7 months or after 1 year, again the patient comes, and he has been having now at present symptoms of mania. So what are the symptoms of mania? Like he has a very elevated mood, he's not sleeping, and he's not feeling fatigue at all, and he's over sexual, over religious, over talkative. These 3-4 features are pointers for mania. So in that patient now becomes as bipolar patient, and we'll label the first episode as bipolar affective disorder, currently depressive or currently mania. So bipolar disorder is a long-term diagnosis. It is a longitudinal diagnosis, and on further episodes presentation we make a diagnosis. In bipolar depression, there are subtle differences with unipolar depression. Bipolar depression patient mostly present as increased appetite, increased sleep during the day, and on the contrary, in unipolar depression, mostly present as decreased appetite, decreased sleep. So these are subtle differences. And bipolar depression mostly has a seasonal association. Mostly patient or his attendant will come and say, Doctor Saab, whenever this particular season comes, mostly in winters, they say like October, November, when the season is changing, the attendant or the patient will come कि डॉक्टर साहब ਜਦੋਂ ਵੀ ਮੈਨੂੰ ਹੁੰਦਾ ਜਦੋਂ मूड लो ਹੁੰਦਾ कि ऐसे टाइम आके शुरू हो जाता है हर साल या हर 2 साल बाद इस तरह ही ਹੁੰਦਾ or during change of season from winters to summer mostly the patients come in mania. So the seasonal affectivity is always present. And now comes the reason for such seasonal variation of symptoms. So basically, whenever we in any psychiatric disease like depression or mania, whenever we find a seasonal variation, we always go for in-depth history taking or in-depth evaluation also, because seasonal variation, what studies say these days, that there is always a underlying metabolic derangement that has been undiagnosed. Like for example, like vitamin D has a very important role in both in unipolar and both in precipitation in episode of bipolar depression also. And along with that, as you were saying, that diabetes and hypothyroidism, so they are also, whenever maybe they studies do say that whenever sugar profile is deranged, there can be a precipitation of an episode of bipolar affective disorder, maybe any episode, maybe depression or mania, or maybe when the thyroid profile is deranged, he or she can have a derangement seen. So basically, bipolar depression and seasonal variation is mostly associated. I mean, bipolar depression and seasonal variation, and unipolar depression has a lesser association with seasonal variation. And whenever a bipolarity, we think of bipolarity, we always go for underlying evaluation of metabolic, like thyroid profile, like diabetic profile, vitamin D profile, and any kind of viral illnesses if present. So these are common associations which we try to find in our routine practice. So your mic is muted.
Am I audible?
हाँ जी sir, हाँ जी.
Audible?
हाँ जी sir, yes.
Okay. So thank you for elaborating the different seasonal variation in depression. And secondly, I would like to know, Dr. Piyush, about something, a very short brief about what are the biochemical changes happening in our nervous system, or in terms of what is the pathophysiology of depression.
Okay.
And just to understand that how the different component of our neurohumoral system, like circadian rhythm, they affect the symptom of depression. So will you please elaborate in short what is the pathophysiology behind depression, and is there some genetic association of depression, and what type of depression the people they are more risk of genetic transmission to the or at a high risk of developing depression in a family members.
So basically, the neurochemicals that are responsible for the precipitation for the depression or mania, most common of them are dopamine, serotonin, norepinephrine, GABA, and glutamate. These are the most commonly found neurochemical disturbances that we target for. That is why for the treatment of depression also we have drugs like selective serotonin reuptake inhibitors that increase the serotonin levels, norepinephrine reuptake inhibitors or blockers like that. So basically these are disturbed. Coming on to the genetics do have a role. There is a lot of genetic association, but it is more for bipolar depression and lesser for unipolar depression. Whenever there will be a genetic predisposition present, the onset of the episode of depression will be always earlier in life, and the lesser the genetic association, the onset will be in the later life. For example, episode of depression presenting in 40s and an episode of versus an episode of depression presenting in 20s. The episode presenting in 20s might have, or there are more chances of it being genetically associated, or it being having some kind of history taking. A family member may be positive for any kind of mood disorder, versus an episode that is presenting in 40s that will have lesser chances of a genetic predisposition or a positive family history. Sir, yes, sir.
Okay. So, thank you very much regarding the pathophysiology. And then I would like to, as a physician, understand that how you do a screening of a patient with depression, and what are the various tools to diagnose depression. And just please tell us in brief, in a simple manner, just how can a physician assess a patient of depression, and what are various screening tools and diagnostic criteria.
So first and foremost, coming to tool coming is first and foremost is the history. Like I earlier said, repo formation. Second is history taking. So whenever a patient comes, a detailed history is very important. And whenever a patient gives a history, you always see for suicidality. Or 3 points I personally evaluate whenever a patient I find he is coming on a severe lines. 3 points are hopelessness, helplessness, and worthlessness. Helplessness is in relation to others. Like the patient will say, मैं एक ऐसी स्टेज पे हूँ या मैं हूँ एहो जी स्टेज ते मेरी कोई मदद नहीं कर सकता. Worthlessness, that I am worthless, मेरी कोई औकात नहीं है, मैं किसी काम दा नहीं है. Hopelessness is in relation to future, that there is nothing in future. Now मेरे आगे भी कुछ नहीं रहा ते मेरे को डॉक्टर साहब हुन कोई. Whenever a patient says these three kind of answers to these three questions in positive, you should always raise the suspicion of an underlying severe mood disorder, and you should always send the patient to a psychiatrist. As for the tools are concerned, what are the validated tools? Mostly in psychiatry, we use scales. We have some questionnaires. Scales are mostly questionnaires, and they give us a scoring, and that scoring helps in rating the patient as per his severity. So the most common tools that are available are Hamilton A scale, that is we say HAM A, Hamilton D scale, that is HAM D, Journal Health Questionnaire, that can be used by the physician also, GHP, GHQ, Journal Health Questionnaire, Primary Health Questionnaire. Though the second two tools, what I mentioned about Primary Health Questionnaire and Journal Health Questionnaire, they are very important in diagnosing comorbidities. The HAM A and HAM D are individual. Like HAM A is for anxiety, HAM D is separate tool for depression. But Primary Health Questionnaire, Prime D, there is it is termed as Prime D, PRIME dash D. It has a part that is Primary Health Questionnaire, and that tool helps us in diagnosing the comorbidity. It is very useful in for the physician to rule out the somatic complaints, to rule out anxiety complaints, and to reach to a diagnosis that will help him in assessing the severity if there is any mood problem or any psychiatric issues, and when to refer to the patient. It will depend upon the severity. So these tools, sir, are very useful, and you can also use in your OPD.
I think Prime D, you said Prime D questionnaire.
You can use it PDF on Google. You can search it. Primary Health Questionnaire, Journal Health Questionnaire, and for individual diagnosis for Hamilton D and Hamilton A, HAM A, HAM D, we use for rating the severity. And these tools can also be used for assessing the overall improvement as and when the patient comes to you in the further follow-ups. Like for in the first episode, he may have a higher reading. In the further follow-up, his reading will decrease. Like, sir, we use MMSE for delirium and dementia. for assessing the improvement of the patient. Same way we can use these scales for assessing his improvement over a long period of time. So these tools can be used, sir.
So thank you very much, Dr. Piyush. And definitely the primary and general healthcare questionnaire, I believe, is one of the easiest method to screening for depression, especially for physicians who are very busy in their clinical practice when they are facing large number of patients in their OPDs. But still, these are very useful tools, very simple. I think, Dr. Piyush, they are very simple tools, and you can easily get the PDF copies, and you have to just tick or say yes or no answer, and you will easily came to know whether we need to get a urgent consultation from a psychiatrist or not. So, as a physician, I personally believe that we should always keep in mind major depression as a comorbidity, especially when we are dealing with a chronic condition like diabetes, hypertension. Especially in my practice, the patient who are on rheumatological disorders, taking steroid for a very long time, they are also very prone to develop depressive illness. And therefore, these questionnaires are very helpful, and we can easily employ these questionnaires to screen for major depressive illness and comorbid anxiety, and then we can plan a holistic treatment rather than only looking into the medical disorders. And then I will like Dr. Piyush to please then elaborate about how you manage depression, major depression, unipolar or bipolar depression. And please tell us how a physician can see. Most of the time we are seeing large number of the patient with depressive illness, and how a physician can tackle depression, and then how a psychiatrist manages depression. And please guide us when to refer a patient for a psychiatric consultation, and please clarify this issue to us, that to what extent we can manage, and what are the line where we should refer or get a consultation from a psychiatrist, so that patient can get the benefit of psychiatric consultation as soon as possible.
Okay. So, sir, there is no cutoff point that when the patient needs to be treated from a psychiatrist and from a physician. There is always a CL consultation that should be going on. But I feel personally that whenever a patient comes to the physician, and mostly this is the trend, whatever psychiatric illness may be. So if stressor is there, like for example, you ask the history, and as you said, the patient, mostly female patients, start crying, and you have found the stressor, and you see the patient is clearly depressive since last 10 to 15 days, or it is not a very long term episode. So you can always start some kind of antidepressant, so for the betterment of the patient. And along with them, that in these kind of cases, if there are primary diagnoses like diabetes mellitus and hypothyroidism, and along with that these subtle symptoms of depression are there, you should always try and treating that part also in the first instance. And if following 10 to 15 days of appropriate therapy, you feel that there is no relief of the symptoms, you should send the patient, or you should refer the patient for a psychiatric opinion. But if you feel that the patient has come and he has psychiatric issues since very long time, and there have been multiple episodes in the past, or multiple suicidal episodes have been there, or any kind of psychiatric illness has been there that has been significantly deteriorating his life, his attendant's life, or the homely environment, so in that case the psychiatrist approach should be priority. And then if there are any medical complaints, that should be addressed simultaneously, but the psychiatric complaints in that case needs to be managed by the psychiatrist on priority. So there the what kind of cases physician should manage of psychiatric illness, they should always try and manage those cases that have a lesser duration and they have a newer onset. So that will be a better approach in my opinion. Sir,
from a attendee. Uh, it is Snehal.Khan Wilker. So he is asking very important question. Commonly, we are encountering large number of the patient in our emergencies with anxiety in during this pandemic. So he is asking that how you address a patient with severe anxiety in emergency. And continuing with this question, yesterday I got two young females in emergency with severe anxiety, complaining with breathlessness, palpitation. Though their parameters are that they were hemodynamic. Both females were hemodynamically stable. Saturation was normal. Routine investigation within normal limit. So, but they were suffering. They came with the severe anxiety in midnight, and both of the girls, they were young girls, saying that we are suffering from COVID. So there is a very important question. So would you like to please address this question? That how you will you deal with the patient with panic attack during this tough time of COVID-19 pandemic?
okay, sir. Sir, the patient, if a patient presents to us, like you said, there were two cases yesterday, and in the chat box that someone has mentioned. So, such cases, first we always take the history. If it is a very acute precipitation and there have been no prior episodes, like before the COVID era or before this episode, she did not have any kind of episode. So it can be acute stress reaction. There may be some kind of stressor, or maybe an acute panic attack. So we always first take the history, reach a provisional diagnosis. We keep DDs like acute stress disorder. Second is panic attack, and we manage the patient symptomatically. Like we give benzodiazepine. Most commonly, the routinely used benzodiazepine is clonazepam 0.5 to 1 mg dose, and we administer that. And along with that, apart from the medication, we always counsel the attendants and take the history. After taking the history, we always counsel them that don't worry of this episode, and do not think that these are physical symptoms. As you said, all the routine medical checkup was to the baseline and there was nothing at all on clinical. So we always try and counsel the attendants, because mostly in such cases the patient gets immediate relief after administering a benzodiazepine, but the attendants are the ones who are more concerned and who also have anxieties. I think personally that they are having more anxiety than the patient. So we should always tackle the patient and along with the attendant. We should not think that our target is to bring a relief to the patient by giving a benzodiazepine only. No, we should always have a approach of maintaining and a rapport with the attendant and counseling them and settling them also, and saying that don't worry, this episode will be tackled with these medication, and this is not due to any kind of underlying medical disorder. You need to just have a caution that come on continuous follow-up, and along in the follow-up do keep a contact with us of the patient and of your contact also. So we will let you know better in the coming time if there are any psychiatric issues that are significant and those need to be addressed. For the moment, this episode will be settled very fast with this medication, so do not worry at all. But we should always have a journal medical checkup so as to rule out and be 100% sure that this is not due to any underlying medical disorder. That is more important, because psychiatric issues, they present as emergencies, but they do not tend to have a life-threatening effect on the patient. But any medical emergency can always have a life-threatening aspect. So medical emergencies are mostly need to be ruled out, and this is the way I think we should handle. And in the long, whenever the patient starts coming to us, we can use psychological therapies, CBT, biofeedback, and routine lifestyle changes, and how to keep themselves away from COVID. In general, what we as psychiatrists are promoting these days, that keep a routine lifestyle, proper time of sleeping, proper time of eating, lot of fruits, lot of green leafy vegetables, brisk walking, less of tea and coffee, more of lukewarm milk. So these measures, along with CBT, along with biofeedback, these all can help along with the counseling of both the patient and the attendant. So, in my opinion, this needs to be done for such patients.
Please tell Dr. Piyush, please tell us about in brief about what are the various drugs you will use in a patient with acute panic attacks in emergencies. Just in brief, so that we can address the question of Mr. Snehal in detail. I think he would like to know the drugs which are usually recommended, which give a patient a quick relief of impact.
Okay. So we mostly use clonazepam, 0.5 to 1 mg, up to 2 mg it can be used, or propranolol also can be used 20 mg or up to 40 mg, as it is a beta blocker. If the patient is agitated or aggressive, and she may be, at times the patient becomes harmful to themselves, like they hold a blunt or sharp thing and they try to cut themselves, they can be sedated with injectable drugs like haloperidol or lorazepam. This is the mainstay treatment for that particular episode, and most of the patients get relief with these 3-4 drugs, either of them, as per the requirement.
From Mr. Paresh Doshi, that is in a modern era of when all of us are surrounded by a large number of devices in form of mobiles and various other type of digital devices, and we are spending lesser time with nature, rather we are spending more time with devices. And I have seen in a families, people, they are more akin to their mobile rather than talking to their parents. I remember one of my relative, I visited their home last year, and when I entered them, though they have got 2 sons, and everybody was there in their own room sitting and enjoying on mobile phone. So the question is very relevant, that is digitalization is affecting our human beings. That is, depression is one of the manifestation of the overuse of digital devices like mobile phone. We are, especially in a younger generation, they are spending more and more time on mobile phone rather than with natures. So what is your take on this question? I think Dr. Paris will be addressed. Question will be addressed by this question.
So definitely, based on the law of emotions, we feel emotions when we are in contact with something that is tangible, when we touch that thing. So the emotion that arises by the real presence of something, that same emotion cannot be present on using the same thing in a virtual form, like we use telephones, and in particular also, like when we keep on meeting in the hospital, we feel warm towards each other and affection in a more good way when we meet in person or we talk in person. And there are many topics we can discuss when we are face to face. That means we get connected very easily when 2 persons meet in person. And in virtual use, there are always some restrictions, or there is not that touch to reality as we see in real. So definitely this is leading to the emotional there are problems with emotion. Some people have suppression in their emotion, so they have been creating anxieties in their subconscious minds, and these anxieties are responsible for some or the other form of psychiatric issues that are more relevant in this COVID era, because we have been cut off from the rest of the world, our relatives, our friends. We have not been frequently in contact with all of them. So we are using technology more and more, and I think this will further deteriorate our mental health in the coming times if this situation remains and such, unless and until we attempt to apply some basic lifestyle changes. So that will be good for us.
His second question is in continuation is, for how long we should use a digital device in a day? That what you as a psychiatrist recommend? Is there any study or any recommendation from psychiatric associations that how long you should use a virtual device or digital device
Sir, I don't have any such study to quote. Maybe there are studies, but for the moment, we should always use such kind of devices as and when required. For journal browsing, like for example, people have the knack or the habit of using the Facebook for one or the other thing, or WhatsApp, keep on sending good morning, good night messages, good afternoon messages, Ganesh Chaturthi, and all. We should abstain from such kind of things because it creates us being more dependent on the technology for any kind of fulfillment. Like for example, before the WhatsApp was present, we always used to call each other for a greeting for any kind of occasion, but now we are always sending messages. So we should always restrict ourselves to only required when it is mostly required. Like for example, we are doing the webinar and we are being online, so to that extent that is acceptable and that this is good, so we should avoid it.
I just want to answer his question, Mr. Paresh Doshi, that I as a physician, we are from 80s or 90s generation. And when we were in childhood, we used to spend more time outside activities in playing in a ground with our friends rather than playing video games. So I think nowadays, if we see the kid, there is a dramatic shift in how they spend their time. Most of the kids, they're spending time with devices like mobile phones, like video games. So I think it is, as a physician point of view, it is increasing the risk of obesity, and it is the risk of metabolic syndromes, increasing the risk of hypertension, diabetes. And if you see the literature nowadays, studies are coming in India, especially the younger people are there suffering from acute myocardial infarction. MI, less than 30-year population is markedly increasing nowadays. And it is because when you are using digital devices at home, you are more prone to having a sedentary lifestyle, more prone to be eating a lot of stuff without any hunger, and more prone to be smoking, more prone to depression, anxiety, obesity. Ultimately, these all risk factors are nowadays are well known in younger population. It was not there in 80s or 90s population. If you still today see people from 80s or 90s, they are not as obese as the people from later generation. So I think there is a dramatic shift in how our younger generation is spending their 24 hours in a day. So I think we should spend lesser time on digital devices. We should use digital devices judicially, only for our professional benefit. Only for professional benefit. I don't recommend using these devices for watching videos and watching useless videos. Okay, if you want to see some professional videos for your professional knowledge, that is okay. But using useless video which have no relation to you, I think it is creating a lot of anxiety, stresses, watching violent videos on a phone 24-hour days, playing video games. So it is creating a lot of anxiety. And I think we should not use digital devices without any need. For example, sitting all day and using digital devices, messaging on mobile phone, this should be discouraged, I think. So they are actually detrimental to our health, not only to our physical health, but mental health also. So I have seen a boy in my OPD. I think Dr. Piyush, you remember, the boy was using mobile phone up to 5 a.m. in night from last 6 months. And he landed up into severe anxiety and used to become agitated when her mother used to stop him from using mobile. And so this is why I believe that we should use digital devices usually only for professional purposes, not for spending time. We should spend time with our family, with nature, rather than spending time with digital devices. Because this, yes, Dr. Piyush?
So mostly these days I have seen many of my relatives, young mothers, that like when they need to give meals to their child, they often start something on the TV or hand him or her the phone, and the child watches the YouTube or the videos, and he eats the meals along with that. So this is a very bad or very negative. This is a very bad thing. It will create a negative connection with the use of mobile phone and his eating tendencies. And in the long run, when he grows to become an adult, there may be eating issues. There may be many disorders. So we should always be focused as to how we are dealing with our children. We should lesser the use of technology, particularly in children, and we as adults should always abstain from using any kind of digital devices, mostly at night after 9 p.m. or 8 p.m., because direct light always hampers our sleep, disrupts our sleep architecture, and most commonly sleep disturbances are very common these days. Maybe sir is also seeing patients in OPD, and often the patient complains ki neend nahi aandi. So sleep disturbances are in again connected with metabolic disturbances, hypertension, diabetes. So this whole is a vicious circle, and we should always be careful what to do and what not to do. So these things need to be checked. Sir,
Yes.
sir, I wanted to ask you, or if you can brief us just for last few minutes about vitamin D role in these days, because I'm also using it and I'm seeing patients are having many problems, and some physicians are still at this point also. They are not much more concerned about vitamin D deficiency, but I think as a psychiatrist, it is very important and it should be the priority these days to ask for the symptoms of the same or about the eating habits that can give us a pointer toward the deficiency or not, and their role in depression.
See, Dr. Piyush, vitamin D deficiency is very common in India. So now there are studies available which suggest that we as an Indian are suffering from vitamin deficiency. It is a reality. It is not a myth at all. We are not the generation nowadays. I told you, our generation, even nowadays, we are spending very little time in sunshine, and the best time to do get a vitamin D is during peak hour of sunlight. Recommended time period is around 11 a.m. to around 2 p.m. in a daytime, and minimum at least 30-minute exposure to sunlight is required to have an adequate daily production of vitamin D. It is not a myth, it is a reality in India. Our younger population, because of variety of reasons, number one is, I told you, we are spending more and more time indoor rather than outdoor. Second issue is the dietary issue. Nowadays, as I remember my childhood, we were taking more and more homemade foods, a lot of butter, lot of ghee at our younger age, and we were taking a lot of fruits, vegetables, and homemade food rather than taking junk food. But if you compare today's younger generation, you will see that no one is interested in taking homemade food. So first of all, there are adequate evidence available in literature that in India initially it was thought that we people we are not having vitamin deficiency. We are not Western population as compared, but nowadays it is not a myth. We are suffering from vitamin D deficiency, and nowadays physicians are more and more physicians are evaluating patient for vitamin D deficiency, and vitamin D is a very important vitamin which is various nowadays unfolding. Our science is unfolding various benefits of vitamin D, starting from immunity, okay, to prevention from cardiovascular disease, prevention from pathological fractures because of osteoporosis. And so, like in COVID-19 pandemic, vitamin D actually is a vitamin which help in boosting up the immunity, right? So vitamin D deficiency is not a myth in India, it is a reality. And there are various sources of vitamin D, but best thing is, if we cannot spend time in a sunlight, we can take dietary supplement from like cod liver oil is one of the very good source of vitamin D. a non-vegetarian diet is a good source of vitamin D. And another thing is that if you find any deficiency, you can measure the vitamin D and you can supplement with the vitamin D. So it is not a myth, vitamin D deficiency in India. So likely it is. There are studies suggesting of association of vitamin D with depressive disorders. So I think secondarily the various disorder like hypothyroidism, diabetes, and they are commonly associated with the vitamin D deficiency. So it is not very surprising that for a patient with vitamin D, vitamin diabetes and hypothyroidism having vitamin D deficiency, they will also present with the depressive illness. So there is a plenty of evidence that Indian population is vitamin D deficiency, and not only the urban population is vitamin D deficient, but in last 7 or 8 years of my practice, we are seeing that even our rural population is also vitamin D deficient. So though there is less prevalence of vitamin D deficiency in rural population, but still they are deficient. So it is not a myth, it is a reality.
Then last, I want to conclude with the management if there is time. I think management has been missed. I'll, in a very brief way, about how to manage such anxieties and comorbid depression. I'll just name the drugs and the non-pharmacological measures. And the pharmacological measures, mostly drugs that were conventional drugs were TCAs like imipramine, nortriptyline. They are also present or used today also, but they are associated with cardiac side effects. So we as psychiatrists mostly make less use of them. We prefer the use of SSRIs. SSRIs are mostly escitalopram, that is being most commonly used by both physicians and psychiatrists. Along with that, other SSRIs like sertraline, fluoxetine, and paroxetine are most commonly used. Sertraline is cardiac safe, so we can use it in the specific profile of patient. And along with the drugs, we need to be careful about how to advise the patient the non-pharmacological measures. They are basically lifestyle modification, proper time of eating, breakfast, lunch, dinner, timely water intake, brisk walking about 40 minutes daily. It can be broken in two sessions, morning and evening. Time to sleep, time to wake up should be in a proper way. 11 a.m. as theoretically proposed, and wake up time should be near about 6 to 7. And along with these measures, you should always, as a physician, you should always be careful that if any psychiatric patient comes and he is on any psychiatric medication come with a problem of withdrawal. So we should always be careful as how to manage those patients who are already on medication. Like for example, paroxetine has a very shorter half-life, and mostly patients come and present to the physician, and in case a physician stops that abruptly, the patient will develop withdrawal effects. So these things have to be kept in mind, and they should be managed by consultation liaison. So we should be careful while treating and approaching such patients. And we as psychiatrists also, we should always be careful as to how to manage the patient of comorbid anxiety, depression, and any physical illness. Like some patients come to us and in the long run they develop some kind of physical illness, and mostly the patients say, "Doctor साहब, मैं दूसरे डॉक्टर साहब को नहीं जाना कि मेरी ਤੁਹਾਡੇ ਨਾਲ ही है, तुसी पा दो." You should abstain to that extent. You refrain yourself, because in that case you are not the technical person to administer insulin or start kind of anti-diabetic drugs, because you have not done any kind of post graduation you have not much expertise in that field. So you should avoid in keeping the patient to you and avoid him from going to the physician. You should always refer to for the physician's opinion. Along with that, advise him to continue both the medicines. That is the better approach to treat the patient. So with this, I think most of the topics have been covered. And Dr. Parminder sir, if there are any...
I just want to add that Dr. Piyush has rightly said that we should always, as a physician, we should always try to screen patient with comorbid depression and anxiety. And whenever possible, if we are facing that patient is chronically suffering from this issue from very long time, and the patient has suicidal tendency, and if a physician understand, he think that he need a proper consultation from a psychiatrist, I think we should not hesitate to take consultation from a psychiatrist. And secondarily, another thing I want to add is that as a physician, we should try to see the patient holistically. We should not be focusing only on medical issues. So we can use in our OPD practices small tools, general questionnaires, and primary health questionnaires, and we can screen the patient for depression. And I have seen many diabetic patient and hypertensive patient managed on a same medication, same dose of antihypertensive and anti-diabetic drugs when we addressed their comorbidities with the help of a psychiatrist. So it is not only always we should manage the patient with antihypertensive drugs or anti-diabetic drugs. We should also try to address their psychological issues also, or their psychiatric issues also. So similarly, I have seen many diabetic patients managed even on a half a dose of OHA when we address their depressive illness. So a physician should always keep in mind that he's not only seeing a patient of diabetes or hypertension or other medical disorder. It may be a case of major depressive illness which is coming along with the medical disorder. There is another question from Dr. Ashwini that Dr. Piyush, how to in this era of pandemic, majority of children are spending most of the time at home. So he is asking any suggestion from you that how to handle stress in kids staying a very long time in.
Sir, I don't have kids, so I don't have that experience, sir. You are a better person as to how Dr. Parminder.
You see, I have two daughters, so I can give you some suggestion. I think first of all, refrain them from using any mobile phone. Number one. Number two, you can engage them in different activities like coloring or painting. You can ask them to join in kitchen to help their mother in cooking activities, right? Or whenever possible, you can go for jogging outside, and by keeping in view the social distancing in mind. And so I think these are the few suggestions. And secondarily, there are other kind of games which we used to play in our childhood, like Ludo. You can play at home. You can play word Sudoku, that is the world finding games with your kids. So there are very ways you can spend time with your kids. And secondarily, you see, I think our kids, it is better our kids play with the toys rather than they spend time on playing with video games. If a children plays with toys, and it is he will develop a better psychological mind rather than playing with the video games. Video game will be more aggressive. What he is doing in video game is trying to achieve a target. He's more anxious, and whenever he's sticking to his chair, he is asking for more and more food, junk food on when he's playing on a video game. I think so we can engage them in other activities other than using mobile phones or digital devices or video games. We can these are the various usual suggestions you can use, but definitely mobile phone should be restrained from kids until I personally believe, there is no study available, but I personally believe as a father that before the age of 18 years of age, no kid should be allowed to be excessively using mobile phone. So they should not be used. They should not be allowed to use any mobile phone. So they are more prone to be exploited on very porn side by. You have seen many news that children, they were secretly chatting with very people on WhatsApp, and they exploited badly. Even they are killed by the various incidents happened during past 10 years. So I think definitely we should engage children in activity other than the digital devices.
And gaming addiction also, sir, it is very common. And these days in OPD also, games like patients with addiction to games like PUBG. These were I thought previously that this is just a myth, but patients are coming with PUBG addiction and they are deteriorated to the same extent like So we should always be careful, as sir told, कि we refrain from giving mobile phones to the children. Indulge in board games like Ludo, Carrom board, chess, and engaging them in routine household works. So that is good, and this is the main advice. So with this, I think questions have been covered. Hello.
Hello, Dr. Piyush,
I think most.
I think most of the question has been addressed.
Yes.
Yes.
I will give back to Mr. Vinod.
Yeah.
If you want to ask any question or there is any issue left, we can discuss.
So thank you very much, Dr. Parvinder and Dr. Mahajan, sir, for all the relevant questions you have answered and topics, and even from the question answer has been also addressed perfectly. So, sir, I thank you, sir, and for that, sir, definitely. I myself, Vinod Verma, and I am a regional head from Elton Laboratories Limited, North Zone at Pentagate Division. At the outset, I am take this opportunity for share. Thank you very much for sharing your expertise on this very important topic of comorbid depression and anxiety. And the information you have shared, sir, definitely will useful for our practical usage also, sir. And I'm sure, sir, many doctors who are watching it has been benefited from your experience by our faculty, sir. I would also like to thank Dr. Parminder and Dr. Payush Mahajan, sir, for bringing all the relevant points into the discussion and making these sessions are very useful and very beneficial for the doctors. I would also like to thank at this point of time for those doctors who have joined us this webinar and helping us making this program a very fruitful and successful, sir. As a healthcare, as a healthcare, sir, we all are committed, and we salute our continued prescription support for all our key brands, like such as we have my Nusita Plus, Nusita Light, Nusita Plain, Nusita Mini, and even Melzap MD and latestly approved Melzap Films. And our brand are strictly available, mostly available in all the chemi shop. But if in case any patient find any difficulties, we will request you to connect back to us, and we would like to serve the patient at their home also, sir. And today, once again, finally, sir, I thank you, and please take care of your health as you are always taking care of patient health, sir. So thank you very much.
Thank
you so much, sir.
Thank you.
Thank you, sir. Have a good day once again.
Okay, thank you, Dr. Parminder.
Thank you, Dr. Piyush. Thank you, Mr. Vinod.
Okay.
Thank you, sir.